welcome and thank you again for joining us. I guess I can't complain that it's early for me at 5:30 since it's even probably earlier for you. So welcome and thanks, and look forward to hearing this talk.
Thanks, Sushil, and thanks, Srinivas. It is so good to see you, although I share your comments, Sushil, that I wish this was in person, and that's what we talked about last time. This is one of my favorite meetings, and the memories that we made in Hyderabad in the years before are very cherished. And to the rest of the panelists, Praveen, good evening and good to see you. So it's a tough act to follow when Marty Leon sort of gave this talk last year, but I will give it a shot. This is clearly an issue that is important increasingly. So I'll start off with a case that I just saw last month. RF, 63-year-old male, CEO at a tech company, is quite active, a runner with a very hectic travel schedule. And he's been feeling more winded and fatigued, and he now can only run 2 miles compared to his usual 5 miles. So notice this is not an old, frail, 90 or 85-year-old TAVR patient. This is a pretty healthy, otherwise healthy guy. His transthoracic echo with severe aortic stenosis, heavy calcification, a peak gradient of 5.4 meters per second and a mean gradient of 70 millimeters per second. Just looking at the echo, it was unclear if it was a bicuspid valve, but given his age and demographics, that was the suspicion. His coronary angio showed non-obstructive CAD. And as is quite common in our practice, and I suspect in other practices as well, he's already researched TAVR and is very reluctant to undergo SAVR. In fact, some of the patients will actually tell us what valve they think they should get in terms of the brand. So this is a CT. This obviously is fairly confirmatory that it's a bicuspid aortic valve, a Sievers type 1. And those are the measurements on the side with an annular area of 512 millimeters squared and a perimeter of about 84 millimeters. So we'll get back to this in a second. So as you guys all know, in AVR in young patients, in general, mechanical valves have extended durability, but it comes at a cost, and the cost is lifelong anticoagulation. Now, bioprosthetic valves, on the other side, have a finite lifespan, are subject to structural deterioration, but the benefit is that they do not require anticoagulation. Many young patients, such as Mr. RF that we just talked about, have very active lifestyles, and they like to avoid surgery. In fact, our surgeon who works with me as a partner frequently says, if it was me, I would never get the surgical valve. He said, have it biker, and say, who wants their chest cut open? Pretty much nobody chooses that option. So the advantage, of course, is that in a surgical valve, all the native valve cusps and annular decalcification and degenerated prosthesis can all be removed, whereas in a TAVR valve, the technology is using the native valve leaflets for anchoring. And then in younger patients, one of the other concerns is whether there's accelerated bioprosthetic structural valve deterioration. Let's see. So TAVR in young patients, if I had one slide, I would say this would be it. It's never been systematically tested. A lot of the data is anecdotal, based on our experience, and then extrapolated from the older data subsets. There are, of course, a lot of unanswered questions, and by this I don't mean that there is no data on durability, coronary access, the risk of redo TAVR. It's just that this is a field that we continue to learn more about. And balancing these questions with the patient's preferences is a very common scenario, and I think thinking about lifetime management in this population is absolutely critical. So let's start off with what the clinical evidence is. And this is here. I mean, there's really not that much very rigorous evidence of TAVR under 65, which is my topic for the day. In terms of randomized trials, there is Notion, Partner, Evolute, Low Risk. And then there are some non-randomized but prospective studies with low-risk TAVR or LRT, then low-risk TAVR bicuspid, and Evolute, low-risk bicuspid. And then there are some other registries which are observational. So here's how I synthesize this data in one slide. In general, the mean age in all of these trials was 68 to 79 years. Obviously, as expected, there was an overall low prevalence of comorbidities. There were hardly any Sever's type 0 bicuspid aortic morphology, which means that some segments, some subsets anatomically are underrepresented. However, it's pretty clear that the all-cause mortality with TAVR was lower compared to surgical AVR at pretty much all early timeframes, 30 days, 1 year, 2 years. The overall stroke rates were numerically lower with TAVR in all the studies, and then statistically significantly lower with TAVR in PARTNER 3. No significant differences in moderate or severe paravalvular leak, especially with the newer generation devices. And that, I think, has to do more with improvement in both technique as well as the devices themselves. Consistently, mild PVL rates remain higher with TAVR in all the studies. As expected, new permanent pacemaker implantation is higher, significantly higher in TAVR compared to surgical AVR. And then also, as expected, higher with self-expanding rather than with balloon expanding transcatheter heart valves. And surgery, as one might think, has a higher incidence of new onset atrial fibrillation. So this is one slide that sort of tells us what we know from the data about these populations. But are there unanswered questions? Absolutely. There's anatomic subsets, as I mentioned. So Sever's type 0, for example. What about future coronary access following TAVR? There's our understanding of this has rapidly evolved in the last 2 to 3 years. Durability, we are just starting to get data now that goes beyond the early 2 to 5 year range. Similarly, management of concomitant conditions such as aortopathy, coronary artery disease continues to evolve and has become more nuanced. And then finally, the big topic is the safety and feasibility of what I could call lifetime management, whether it's TAVR in TAVR, but TAVR in SAVR, SAVR in TAVR, etc. So let's take these one step at a time. How about bicuspid aortic valves? So here's some anatomic considerations in patients with bicuspid valves. No surprise that these patients generally tend to be younger. Also, that the randomized trials in low-risk patients excluded patients with bicuspid aortic valve. I mean, some of them followed them as non-randomized registries, but these patients were not randomized in some of the pivotal trials. Now, the real world, of course, is different. In some older TVT data, 3.2% of all TAVR procedures in the US, and I suspect a little higher now, are for bicuspid valve stenosis. What we do know that multiple studies have shown acceptable outcomes for all-cause mortality with TAVR, but higher rates of PVL and stroke, especially with the older generation transcatheter heart valves. Remember, some of these studies also included patients that had no skirts, valves, that had no skirts. With the newer generation transcatheter heart valve, the rate of moderate or greater PVL is dramatically lower. So 14%, for example, with the older generation valves to 2.7% now. The excessive leaflet calcification and raphe calcification are predictors of all mortality, PVL, and aortic root injury. And then the other consistent finding is increased stroke. Although in some studies it's not that much increase, but nevertheless, the signal is pretty clear that the rate of stroke is higher in bicuspid rather than tricuspid valves. There are several mechanisms that might explain it. For example, whether there's excessive aortic valve calcification, whether there's need for more aggressive pre and post dilatation, and then perhaps more frequent repositioning. Part of the challenge with the bicuspid aortic valves also is to do with how these valves expand and what the vector and the calcium forces are. So this is a nice simulation on how valves expand in tricuspid aortic valves, which is the TAV label on this, versus a Sever's type 0 and a Sever's type 1. And you can clearly see that the expansion in bicuspid aortic valves is not the same as tricuspid valves. It's far more impaired. And then even within those subsets, those are different. And this was a pretty elegant computer analysis that was trying to understand TAVR device expansion. So for example, if you look at, this is again from the same series of simulations, if you look at tricuspid aortic valve, the geometric orifice area might be about 644 for that population versus about 460 for a Sievers type 0. The numbers themselves are not important, but I think the point I'm trying to make is that there's definitely different forces and asymmetric expansion in bicuspid valves. Now, what about durability of these valves? As I mentioned, the younger patients with active lifestyle, and that's a theme that comes up over and over in both in our discussions with patients and in this presentation. And they all prefer tissue rather than mechanical valves. And although one might say that the tissue processing and the anti-calcification processing is similar for the transcatheter heart valves and surgical bioprosthetic valves, but crimping, the leaflet anchoring mechanism, the centricity of the stent frame after deployment, they confer some unique differences that one might then hypothesize have implications durability, either in the positive direction or in the negative direction. Initially, there was quite a bit of concern, especially with the very original partner data set, whether these valves are going to be durable enough. But I think most of us now feel pretty comfortable that the available data on the durability is quite good, and at least as good as surgical valves, and perhaps even better. Now, if you take the corollary that the surgical tissue valves last for a long time, and then you look at the data that underpins that statement, there's a lot of variability in how that data has been collected. Traditionally, since surgery was the only option, there wasn't a very robust data set behind structural valve deterioration. So I think this field, our understanding of this will continue to evolve. There is no signal yet for early degeneration, and there are more data to come, both from longer-term follow-up from the core valve studies and the NOTION trials. However, we do have the data from NOTION, which is a 6-year data, and that looks pretty reassuring. As you know, this was TAVR versus SAVR in a lower risk population, patients who were eligible for surgery. And at 6 years, the rate was similar for all-cause mortality and for bioprosthetic valve failure. But the structural valve deterioration, when measured in an adjudicated way, was significantly lower with TAVR. I mean, that difference is pretty astounding. It's 28 or 24% versus about 5%. The other rates of non-structural valve degeneration, such as leaflet thrombosis and endocarditis, did not differ. Now, obviously, this was the older generation, so a higher rate of PVL, but quite reassuring overall. And then freedom from reintervention was again significantly lower with TAVR than with the surgical AVR, although both of them were in the high 90s, as you could expect. So the factors that play in are both patient or prosthesis related, and I won't go over these in details, but recognize that young age, hypertension, hyperlipidemia, renal insufficiency, hyperparathyroidism are some of the factors that are patient related that lead to early degeneration. On the other hand, there are prosthesis related factors where a smaller size of prosthesis, a severe patient prosthesis mismatch, and then absence of these newer anti-mineralization treatments, those are all related to early deterioration as well. In terms of TAVR specifically, there are some factors that we think affect valve durability, although again, this is something that continues to evolve, at least in my mind, and then in the evidence. For example, what is the role of valvular circularity? How do things change with flow characteristics? If you have poor flow characteristic, whether it's due to an underexpanded valve or whether it's due to an obstructive design, then does that impact the longevity? And then finally, thrombosis, whether the confluence of stasis behind the leaflets with an increased use of thrombosis then has a downstream effect on durability. And I think we have some idea, but our understanding of these continues to get more and more nuanced. The next thing that I generally would think about is coronary access. So, as you know, coronary access after TAVI is a challenge, and it's a challenge with pretty much all devices and platforms. I would say that it's more of a challenge with the taller core valve self-expanding platform than it is with the SAPIEN, but nevertheless, pretty much all major platforms extend up the left coronary artery in up to a quarter of the patients. This is definitely a concern for several reasons. One, that as patients age, there is progression of CAD. You could also have ACS, maybe because of coronary embolism, secondary to subclinical leaflet thrombosis. And what is interesting to note is that ACS after TAVR has a pretty high in-hospital mortality of 10% and late mortality of 43%. And in modern day cardiology practice, those data are high. For example, when we see ACS patients, we're not really coding them at 10% mortality in the first year or so. This data, I think, goes up to 12 months. And well, partially, we hypothesized that this lack of coronary revascularization due to difficulty with access are perhaps a predictor of mortality. Certainly, several studies have shown that it's difficult to perform selective coronary angio after TAVR. And those of you who routinely do this, you will appreciate that sometimes it's just tough. Sometimes it could be because of obstruction by the displaced leaflets of the native aortic valve or by the leaflets of the transcatheter valve, could be the metallic stent frame, or could be the commissural suture post of the transcatheter heart valve, which is the configuration in which the frame lies above the coronary ostium and a commissural suture post is directly in front of the ostium. And I know that on the agenda, there's a good talk by Gilbert Tang. So he's absolutely given this a lot of thought as an expert. So I'd encourage you to attend that talk to hear Gilbert's thoughts on where that particular piece is going. Now, compare that to surgical AVR, because in surgical AVR, the surgeon typically will have an anatomically correct commissural alignment. There would be resection of the native leaflets, and also there would be a fairly low threshold for these patients to get concomitant bypass graft surgery rather than unrevascularized or PCI in the TAVR arm. What we do know that even in computerized models and real-world experience, up to a third of patients in self-expanding and up to perhaps 15 to 20% in the balloon expandable valves, the coronary access is challenging. There are now some mitigation techniques that you could do, and we've started to do that almost routinely. Although I'll tell you that these techniques do not confer absolute protection that the commissures are aligned. For example, in the Evolute platform, we look at the hat marker at the outer curve in the center front, and then Accurate Neo. Again, you can improve the alignment partially. Interestingly enough, for at least the current generation SAPIEN valves, they have no impact on the commissural alignment based on the pre-deployment alignment. And then our next generation heart valves are actually designed to ensure these alignments, specifically the Jenna valves and the J valve. So I suspect other players in this, other innovations in this will continue to make this easier for us. And already there are some other designs and products on the bench that will make this a bit easier. Now, when you have concomitant pathology, so this is moving on with sort of comorbid condition, and in general, SAVR is preferred for young patients with bicuspid valves and who also have aortopathy, or who have multivessel disease with high syntax scores or left main coronary artery disease, or patients who have severe mitral valve regurgitation, especially primary mitral valve regurgitation. Now, the caveat with this is that double valve surgery mortality statistics are completely different than a single valve surgical AVR. So a multidisciplinary heart team approach with shared decision-making is absolutely key in these populations. And then the final piece of these is these 2 or 3 related items. So for example, paravalvular leaks. We used to think a lot more about this, but I will say that with the newer generation devices, pretty much the moderate leaks have gone away. Overall, all leaks have gotten better, especially with the newer generation skirted valves. Now, the incidence of mild paravalvular leak, as I mentioned a few slides before, it has always been consistently higher with TAVR. We know that mild PVL in patients with high risk actually does confer a survival disadvantage, and there was some elegant analysis from Sushil actually from a paper from a few years ago that demonstrated that nicely. But we're not really sure on whether mild PVL in patients with low surgical risk confers the same disadvantage. Perhaps that mortality disadvantage happens far later. Maybe it's 5 or 10 years. So those are unanswered questions. Permanent pacemaker remains a huge challenge. As I mentioned, and both in your experience as well as ours, the implantation rates are consistently higher with THVs. And again, it remains a bit unclear on whether having a pacemaker itself in the low risk population would give a higher rate of mortality or repeat hospitalization. There's some ambiguity in data, but definitely concerns us. So it's critical to identify these patients both on good CTs as well as other predictors for PVL, and then those with risk factors for permanent pacemaker, and then individualize that decision making in these younger, lower risk patient cohort. So if you think about this, when you take somebody who's 80 plus or 60 plus, the thinking becomes completely different. The anatomy becomes different. What the patient's expectation from the procedure is completely different. And we have to take into account all of those factors to come with a decision making. This one is the very next talk to follow, and I'm very curious to hear what Dr. Ayer's thoughts on this. So I'm going to skip over a lifetime management piece of this, but this is absolutely something that we think about for every young patient. So now coming back to RF, our 63-year-old tech CEO, this was his CT. And not surprisingly, his procedure was challenging. It took about 3 or 4 repositionings. And finally, we left the valve a little deep. I don't know how well this projects, but there's a slight enfolding that we're concerned about here. And we had such a tough time just positioning it that we said, well, we'll just leave it and then balloon it. And I think you'd probably able to see it better on this picture that you've got under expansion and severe enfolding of this. So in his case, we ended up ballooning it, and ballooning it was actually not that straightforward. The stent frame was interacting with the balloon, so I was concerned that it would actually rupture the balloon. But finally, positioning the balloon, we got it, and he got a great result with no PVL, no pacemaker, and very, very low gradients. So he was pretty happy. So in summary, then, TAVR and bicuspid aortic valve, overall satisfactory clinical outcomes. Significant PVL rarely seen with newer generation valves, but mild PVL remains an issue. The hemodynamic profile of these valves is excellent, and that continues on to 5 or 6 years at least. High stroke rates are absolutely a concern because it's even more devastating when the patient is young and otherwise high functioning. And we have not routinely used cerebral protection, but that evidence continues to evolve. And it's important to look at the anatomic predictors such as leaflet calcification and raphe calcification in risk stratification. And then in general, in a lower risk cohort in the younger patients, hopefully I've shown to you that these have excellent clinical outcomes. But a lot of that is based on slightly older patients, so the extrapolation should be with caution. Think about lifetime management of these valves. It has to be balanced within the heart team and tailored to individual patients. And then until we can resolve unambiguously these questions and issues that I mentioned, we are very upfront with the patients and have a very nuanced discussion with them. And then come up with this treatment decision using shared decision making. So thank you for your attention. And
but I think that's fundamentally the important question. And you've highlighted a lot of different challenging issues: small annulus, bicuspid valves, coronary access, and all of these are going to become much more relevant in a younger patient that has much sort of longer longevity left in them. And I think that's where I always struggle with the conversation, right? Because we're talking about a lot of theoretical concerns. We don't have a lot of data on bicuspids, but the data we have is good, but it's in a selected population. Coronary access is something that we're not going to know for years to come, when it's going to be a problem. We don't have commissural alignment, and oftentimes I find the patients asking the question, if it were you, doc, what would you do? And I'm curious how you answer that question. You said your surgeon said he would never get a surgical valve. I'm curious if you as the interventionalist say, I would not do TAVR if I'm at my age, I would do surgery. So curious to put that question back on you.
Yeah, and we hear that a lot because a lot of patients now are very, very well informed and have researched this. So I think that my answer for myself would be nuanced, and it would depend on the CT anatomy. I have a lot of store in the CT, and yes, it's easy to look at the three Menciers. It is easy to look at sort of the report that your radiologist generates, but I'm old-fashioned. I remember, so she proctored me for my very first TAVR more than a decade ago when we had him to Portland, and I paid him back with some nice Portland beer. And one of the things that I've done since that point is we look at our own scans, not most of the time, not majority of the times, every single time. And once you do that, once you've looked at thousands of these, you start getting an idea. So I would factor that in. So similarly, if whether your groin access is great, whether you have pre-existing bundle branch or pre-existing first-degree AV block that then predicts that your pacemaker risk would be higher. What does your coronary anatomy look like? Obviously, it could come that, you have no significant CAD. But let's say if you have extensive plaque and you can see that on the CT, then you know that over time, that is going to progress. So we use a lot of those as discussion points with the patient. But having said that, most patients, I would say 9 or maybe 9.9 out of 10 will prefer TAVR, even those who have a nuanced understanding. Some just say, let's just kick the can down the road and we'll decide when we come. Who knows what you guys will be doing in 10 years. And the others, they still come to that same point. I don't know. What is your experience in your practice?
It is. And I think one of the things I struggle with is I talk to patients about sort of separating invasiveness from risk, right? Surgery is very invasive, but it can be very low risk. And in the end, in a younger patient, it's more, imperative that the question we answer is, can we get a good result? It's not about invasiveness. They'll recover, because in the younger patient, that lifetime management stuff that you discussed is key, because you're talking about what is the next 20 years going to hold for this patient, right? In the U.S., average survival is to the mid 80s, right? I'm not worried in an 85-year-old or 90-year-old, we're talking about 5 years at most, and often. And so the questions are different. And I think that's been my approach. And, one of the biggest data gaps, in my opinion, is bicuspid valves. And I don't know how we're going to fill that data gap, because bicuspid is not one entity. You showed a type 0, you showed a type 1, you showed all these different entities. The calcium patterns are variable. We don't have data on how these valves are going to behave, how the acute result is going to be, and how long they're going to last. And I think that's where I struggle with the question. But I think the point you made about looking at the CT and how far we've come. If I have a 65-year-old with a tricuspid valve with an annulus of 600 or 650, and high coronaries, big sinuses, I feel very comfortable telling that patient, get a TAVR. Hopefully we'll get 10 years. Can do another one, maybe even do a third if they're not a big person. So and I would start with the balloon expandable in that. So then I can discuss how to do the next valve, whether it's another balloon expandable followed by a core valve or whatever new technologies we have. I can map out that scenario. That I'm not sure I have the data to support my decision, but theoretically I can map that out and I feel comfortable. But the converse is, if I have someone that weighs 100 kilos and has an annulus of 400, and is 65, I can't map out a scenario where that person avoids surgery. Now, others will argue in that person, you're less likely to get patient prosthesis mismatch with TAVR. So maybe at 65, you do a core valve, and with the plan of doing redo surgery in the 70s, especially if the surgeon's not going to do a root enlargement. So it's not such a straightforward conversation, but we don't have a lot of data on how complex are the redo surgeries in these patients and things like that. So, these are things that we talk and one of the things in the ACC guidelines, as you mentioned, is the shared decision-making. I always struggle, some of these patients, how much information can you give? I talk myself into circles many times in terms of, what is the right strategy and are we, how are we helping patients make this decision? I don't know, Srinivas, what do you think? In India also, there's a lot of cultural differences, right? People are not willing to have surgery late in life. Lifespan is also a little bit different in India versus elsewhere. How are the conversations there?
I feel in India, probably we can take it a decade less. Suppose if you people consider probably 75 plus there, probably in India, we take it as a 65 plus, probably a cutoff, though we don't have definite recommendations. We have Praveen Chandra and Sanjay also joined. Any comments on that? Otherwise, Dr. Gurube is ready with the case, Sushil. We'll have brief comments from them and then go for a live case from Gurube. We can keep discussing during live case.
So I totally agree with Dr. Kodali's ideas that, hi Saurabh, nice to see you.
Hi.
So
nice seeing you as well, Sanjay.
I've had this conversation in my mind that especially a bicuspid valve at 55, 60 years of age, who is going to get a 19 versus a 21 surgical valve, why not put a evolute there to give a better hemodynamics to this patient and operate after 10 years? What's the big deal? I feel that idea of that it will be available only after 65 years of age is not a good idea. But as you said, there is no data to suggest that.
And I guess the challenge is how easy is it to take core valve out? I think that's where we need, how easy is it to take it out?
It's pretty hard.
They take it out. So I've had a patient who had a problem. They took it out. So I put a lot of stent grafts. They take it out everything. And they're happy to take it out because they enjoy it. But
and it may come out in some patients, not so easily in others, and it might be a root in someone else. So that's, I think, part of the challenge, right? Yeah.
That's true. But I think that surgeon who takes it out should know how to repair the roots.
Yes.
That's an important aspect of it. Can we change? Can we do a Bental? Can we replace the whole thing? Put a new valve with a small conduit there. They should know how to reimplant the vessels in such patients. So this would be not all the surgeons, but I think most of the surgeons in our hospital will do it because aortic surgery is a very common surgery in our hospital. So my surgeon is Dr. Shetty, who sends me a lot of patients doing TAVRs, said, you put this, I will repair it when it comes to cum repair. So he's a
Well, the other point that Sushil just mentioned, I think I can't emphasize it enough, that gone are the days when acceptable was acceptable enough. We are not aiming for acceptable, but generally just in any patient, but especially in young patient. I mean, it's got to be really close to perfect. In our lab, we typically won't even let them leave with a mild unless we've tried everything we're going to try. Sushil, is that your approach as well?
The problem is just not hemodynamics. The problem is the need for a pacer, the need for reoperations. We have to be very sure that what we are doing for the patient is right, who's going to have a young TAVR. So this is my concern, and I don't know, I know the answer. I want to ask you guys that, because you are the guys.
Dr. Sanjay, other people could say that if you put an Edwards valve now and then probably if you operate later, that can be as well done like a surgical valve. Difficult surgery post the core valve, doing a surgery may be more tougher than putting a Edwards valve. I think these discussions will continue, sir. We'll have some more comments from Dr. Gokhale and Praveen Chandra as we move with the case.